By the way, so this case study, you might ask me like, are these case study gonna be in the exam, right? Because you already spent time doing the report and everything. The answer is partially the part that we already learned from last lecture will be in the exam, okay? Not specifically the disease that we will talk about, but the basic information, okay, that we already talked about. So as you already know from the case, those are emphasized in the case study, right? So those will definitely can show up in the exam. Okay, so if you really participate in the group discussion, in this case study making report, then you can be sure that you can answer those questions in the exams already. All right, so let's get started. So we're just gonna go through all the questions together. Okay, so let me see. I'm gonna have to do, hold on a second. So I'm gonna need to look at your name at the same time. Any questions before we start from last lecture? Okay. All right, so we get 11 group. All right. Okay. So first question, what are key symptoms of these patients? Anyone want to volunteer and answer this question? Mm-hmm.
I think I would like to volunteer.
Okay.
So the key symptoms of the patient is dizziness, vertigo, nausea and vomiting upon movement,
Mm-hmm.
um, postural change associated with ataxia. These symptoms um, got worse when the patient moves their head upward, and there is also spontaneous nystagmus.
Okay, yeah. So this is very easy questions, right? But it's important, right? So when you look at the patients that come in, right, you have to kind of list all the problems that they have, right? So here, like your friend's answer, right? So the patient has dizziness, vertigo, nausea, vomiting, and ataxia also, right? So this is like key symptoms, right? And then you have to read, continue to read, and you see that these symptoms were precipitated or get worse when the patients move or they change, the posture, for example. And then another key is the symptom are transient. So it doesn't last, like for the whole day or something like that. It's transient. And then the symptoms can disappear after sitting 5 to 10 minutes. This means something, right? Because the cause, or now we are trying to find out, right? What's caused these symptoms? There can be so many causes, right? But when you pay attention on this detail, you can rule out some of the possible causes, right? So transient and it disappear after sitting for 5 to 10 minutes, right? This is important. And another keyword is the symptoms got worse every time she moved her head upward, right? For example, during placing the book on the top shelf, she's a librarian, right? So every time it's precipitate, when she performed her work. Okay, good, good, good. All right, which group were you from?
I'm from the second group.
Okay, that's good. All right, so now we have 11 questions. So now I'm gonna start calling, okay, each group. So these questions, how is information from A and B important for diagnosis. So body temperature, heart rate, respiratory rate, blood pressure. Why do we need to examine this, information? Let's do maybe group 10. Anyone from group 10? Okay. Nobody from group 10? I have Nguyen Tram uh it's I'm sorry if I pronounce your name wrong, okay? I still can't get used to Nguyen Tram Mai. Are you here? Anyone at all? Group 10? What happened to
You
group?
can try and text the name in the chat.
I think you
Right.
call me
Okay. How do you pronounce your name?
Nguyễn Trà My.
Nguyen Tram Mi. Okay?
Yes.
Perfect. You want to answer this question?
Oh, okay. I can answer.
All right.
With the information from ACE, it like they record the body temperature and the heart rate. So, in this case study, this is a normal body temperature and heart rate. So it means that there is no infection or fever. So with the information from B, they record the respiratory rate and the blood pressure. It is also a normal respiratory rate and pressure, so it indicates normal circulation in the body. So all this information suggests that this patient's symptoms are likely not related to respiratory and cardiovascular dysfunction. I think
Okay.
so.
Okay, thank you. Anyone want to add anything from any group? And the answer is correct. So, but anyone want to add any other information that we get from, A and B? So yes, definitely body temperature. We check, if the patient has fever, right? Because if there's infections or if they have, fever, sometimes you can have the similar symptoms, right? You can have dizziness as well, right? So that's why we check the body temperature, right? Anything else? Anyone want to add? Were you trying to rule out something that can result in similar symptoms? Any group? No? Okay. So basically, let's say if you have, so these are actually the vital signs, right? So vital signs. Any, patients that come to the hospital, usually you check this basic information, right? Body temperature, heart rate, blood pressure, respiratory rate, right? In this case, if in some cases, if you have, problems with breathing, right? You can also have similar problems. Sometimes patients come, these uh, they can cause, some kind of dizziness, vertigo, or faint, right? So those are when you have some problems with breathing and everything. Most importantly is blood pressure, right? So the patient with abnormal blood pressure, especially if they have low blood pressure, right? And if you recall when you learn about physiology, right? So you have blood pressure and then your, you know, blood pressure also determine how much blood flow you have to the brain, right? And if you don't have enough blood flow to the brain, you can have similar symptoms as well, right? You can have problems with, movement. Sometimes you might faint, or sometimes you might feel like dizzy. So similar symptoms, right? So that's when you have problem with blood pressure. Another thing that very resemble the symptom of these specific patients is when they change the posture, right? When they change posture and the symptoms get worse, right? These can be caused by what called orthostatic hypotension. Anyone know what it means? Orthostatic hypotension. I saw it in some of your report. Anyone want to explain? Okay, I see in the chat. All right, so okay. Hypotension, okay, yeah. So orthostatic hypotension is meaning the, hypotension that are developed when you change the posture, right? For example, if the patients lie down and then they get up quickly, or from, sitting and then stand up quickly, then the blood pressure can drop immediately, right? Because blood pressure will from when you lie down, the blood pressure is equalized throughout the body, right? But then when you stand up, all the blood will flow to the leg, right? You have the muscle contractions on the leg, and so everything flow down to the leg, and so you have less blood arrive in your brain, right? So that can cause orthostatic hypotension or hypotension when you change the position or posture, okay? So that's important to think about, right? So everything is normal for this patient. So that means no problems, right, with those hypotension. Okay, good job. Next, what about C and D? Okay, any group want to volunteer for this question? Let's pick group 8 then. Okay, anyone from group 8?
The information from C and D is important because information from C shows that the somatic sensation is normal, so they can rule out conditions like sensory neuropathy or anything that impairs the somatic sensation, while the information D show there's no ataxia while standing in close eye. This means that uh, the patients still have the ability to sense their body position, and since the ataxia only occurs with head movement, so it can possibly support a vestibular cause. Um, that's just that.
Okay, that's good. That's very good. So the keywords that your friend just answered, right? So the answer is correct, right? So somatic sensation is normal. How do you test somatic sensation? Can you give some example?
Somatic sensation is testing whether you can feel
Mm,
pain, or like the test that you said about the 2-point
mm.
pressure.
Okay. Yeah, right. So your somatic sensation from skin, right? For example, right? Do you feel the touch? Do you feel the heat? Do you feel the pain, right? And that information is important, right? And so if you think about the patients, one of the problems with the patients is ataxia, right? Somehow they lost balance, right? So it's a problem about balance. And there can be so many causes that contribute to loss of balance because there are several systems in the body that play a role in maintaining balance. Okay. So now we start thinking about each of the system that play a role in maintaining balance, right? Do you think somatosensation is important for maintain normal balance. What do you think? Anyone? Or group 8 or anyone? Like the sensation from skin, you think it's important or it play a role in, balance at all? Okay, imagine if you walk, let's say if you walk in the slippery, texture, a slippery floor, right? And then you walk with the bare foot, right? Or the shoe, which one would you feel more confident? Which one would you be able to maintain balance better?
Barefoot.
Yeah, most of the time barefoot, right? You probably did not notice that because you always wear his shoes, but barefoot will allow you to sense that information of the floor, right? So whether it's slippery or whether, it's curves or how much you have to pay attention on that, balance. And it will send information to the brain to kind of like, okay, give more control to the leg, right? When you walk or when you stand, for example. So actually, somatic sensation is very important. Okay, so that's why we test whether the patients can sense, those touch, crude touch, fine touch, and those kind of things, right? To rule out whether there is any problems with somatic sensations. Okay, turns out it's normal. D is very important because, like I mentioned, and your friend also answered, right? There's receptor, remember receptors in the skin, in the muscle, in the joint, in the tendon, right? That send the signal to the brain, right? To maintain your posture, right? To make sure that, there's communications between your leg, your bone, your joint, your muscle, to make sure that the brain send enough pressure, right, to those organ, right? So that's why we test. If you don't have the help from vision, that's why you make the patient stand with closed eye, because you want to test the ability of those receptor on your leg, right, to send information or input to the brain. If you open your eyes, you get some information through your eyes, and that's another input telling your brain, right, about your posture. And now you're trying to close the eyes to get rid of that other input and left for here only, the information from your leg, right? So that's why you do these tests, okay? And also, of course, there's not only the leg, right? It's also vestibular system, right? That we talked about as well, okay? So this specific test, ataxia, looking for ataxia in the patients while they stand with closed eyes. This is called Romberg test. Okay, so let's look at this example of this patient. All right, so do you see what happened? So let's look again. So I don't know if the patient is she or he, I can't really tell. But in the beginning, let's say if he open its eyes, okay, right? But then after the eyes is closed, or maybe it's she. So then, the patient fall after the eyes closed, okay? So again, in this case, the most important information that you can obtain is, the sensations from to test whether the sensations, from the proprioceptors are working or not, right? Or the vestibular systems, right? Are those system working, okay? So it can give you useful information to, rule out several things, right? Any questions for this one? So a key important message is this patient, so this specific patient has no ataxia, right, during standing with closed eye. That means their receptors on the leg, on the joint, the muscle can still functions, right? Those receptors can still send information up to the brain, okay? Anyone remember what do we call those receptors? Receptors in a muscle, in joint, in bone. What's the name? Mhm.
Proprioceptor.
Very good. Yeah, proprioceptors, right? All right. So this is the review. We talked about this, right? So somatic sensations, you have, both the skin, especially the proprioceptors, right? We zoom in, we have three major types. We have different receptors, right? But majorly we have muscle, receptor in the muscle called muscle spindle, right? So this will detect muscle length, right? And then we have Golgi tendon organ. This is, detect the strength, the force that put into the muscle. And you also have the joy receptors, which compose of so many different types, right, of joy receptors. So all of these receptors work together and then send the signal back to the brain, telling the brain like, okay, now it's good enough pressure, for this leg, this is what we want, and the brain adjust the signals, right, accordingly. All right. So this is important to maintain, important input for you to maintain balance. Okay. Move on to the next one. Good job, group 8. Let's say no Babinski sign. Any group want to volunteer for this one? Okay, if no, anyone? Let's try group 6 then. Group 6, what is Babinski sign? And why do we have to test it with this patient? Group 6.
The Banikei size the testing method to test the response of and to assess the function of the central nervous system. And because it involves the testing the skin reflex of the feet, and is often used in the setting of suspect nervous system problems such as spinal cord injury or the brain-related problem. So the second question is the how is it important for the diagnosis? So I think it is important for this diagnosis in this patient because there is a normal negative Babinski in this case, and it rule out the central cause of the vertigo, and it support a peripheral vestibular disorder. So if it positive Babinski, it would suggest the CNS pathology problem. That's it.
Okay, very good, very good. Anyone want to add anything to this question? So anyone remember what tract that if the patients show positive Babinski sign, which nerve tracts can have problem? Anything in the tract, it's kind of like a specific tract for Babinski sign. Cortical spinal tract, right? Very good. I got it in the chat. Cortical spinal tract, right? Which is the nerve tract that comes right from the brain, right? From the motor cortex picks from the brain and go down to the spinal cord, right? So those are one important upper motor neurons, right? So Babinski test can be the test to determine whether the patients have problems with upper motor neurons, okay? More specifically, corticospinal tract, right? And the reason why we have to test these patients again, because when you have ataxia, right? Problems with balance, problem with walking, right? So those can come from, any part, right? Including the brain, the upper motor neuron as well. Because if you remember, voluntary movement, right? You need the information sent down from the upper motor neurons, right? So that's why we kind of like want to rule out whether the upper motor neuron is normal, okay? Especially the corticospinal tract, right? So again, this is the test, right? This is how you do the test, and normal response would be, the toe flick down, but then the sign, if the patients develop this sign, Babinski sign, then they will fan their toe, right? So in our patients, which response do you think it would be, A or B?
A.
A, right? Because it's normal. So normal response, okay? So no Babinski sign, okay? Questions, additional question. There is one group of people that even though they are normal, they can develop this response. Anyone know what group of that individual? What kind of, people that,
Could be the children under two, like the Babinski side can be the children can still be normal, but that's all functioning while we doing the test. They also functioning like they got the Babinski sign.
why? Correct
I think
answer.
that
But why? Go ahead.
I think that they haven't developed yet they haven't developed yet the reaction to react that. So I guess that the I guess that their body can act with can act. I can't find the word to say this. I think.
Okay, your answer is correct. Okay, so yes, something is not developed yet, and look at the pathway or the track that we are testing. Which pathway that telling information here? The corticospinal tract, right? Or corticospinal pathway. So yes, actually, the children, maybe less than two, but definitely less than one. Okay, they are not developing, so their corticospinal pathway are not fully developed yet. And because this pathway is very long, okay, it's a huge long pathway, so it's not complete. It's not 100% complete yet. So when you test it, they can respond this way. Okay, so usually most of the cases in 1 year. Okay, all right, very good. Otherwise, when older than that, everyone should have this response. Okay, and again, this is a very important test. If the patients come in the hospital unconscious, this is a very good test to look quickly to the upper motor neurons also. Okay, all right, good job. Wow. Okay, we are F. So any group want to volunteer for this question? Deep tendon reflex. Okay, if not, I will call maybe group 2. Anyone from group 2? Okay, anyone from group 2? Tran Kanshi. Group 2.
about the deep tendon reflex. So it's an involuntary muscle contraction respond to a quick stretch of tendon, and it is an involuntary movement. So the underlying mechanism is the spinal reflex arc and brain from a stimulus, which is a tap at the patellar tendon with a reflex hammer. This stimulus causes a signal will eventually be delivered to the sensory receptor to detect, and the sensory receptor will trigger the sensory neuron, activate the sensory neuron, and further signal will be transmitted to the spinal cord. The neuron in the spinal cord will receive a signal from neuron 1 to neuron 2, and between two neurons there will be an interneuron will responsible for the excitatory or inhibitory signal. And in this particular case, excitatory will be sent to the quadriceps and cause the muscle to contract. And at the same time, inhibitory will deliver to the hamstring and cause the muscle reflex. Both inhibitory and excitatory will be like balanced. Accumulate several signal to muscle. Also, the final response is the leg is kicking, which is the reflex. So this is important for diagnosis because this will detect if the patient has reflex or not and examine the PNS damage. So normally if a lesion occurs, the reflex will be much weaker or more severe and there will be no reaction at all.
Okay, very good, very good, very good explanations for a mechanism as well. And any additional answer? Anyone wants to add anything? Especially like what else that you can get from the diagnosis from the result. So your friend answer, we check peripheral nerves, right? Lower motor neurons, lower motor neuron is normal, right? What else can we tell from if we say deep tendon reflex are normal?
Other than figuring out that the lower motor neurons are normal, we
Mhm.
can also reconfirm that the upper motor neurons are also normal.
Very good. So if the upper motor neuron is having problems, what do you expect to see?
If the upper motor neuron has problem, then we will have hyperreflexia because the brain is joining to control the range, speed, and force of the reflex.
Okay, very good. So that's a good review, right? So good job, everyone. So this is exactly, right, your friend just explained, right? And we learned this in the class. So very good explanation. Hopefully everyone can explain the same, okay? So how the reflex occur, okay? And yes, it's important because it tell you whether you have normal lower motor neurons or upper motor neurons, problems or not. Okay, so it will be one of the information too that can tell you. Then rule out again, ataxia problems can come from upper motor neurons and or lower motor neurons too, right? So this can be another test that you can confirm that. Okay, good. Right, so this one G, okay, I put the wrong box, but the G, how is information from G important for diagnosis? This one is easy. Anyone want to volunteer? Okay. Uh, group, maybe group 3. Anyone from group 3? Vu Tui Min. Uh-oh. Wutumin is missing. Okay. Wutumin 1, 2, 3. All right, I mark missing then. Ligiamin. No one from group 3 at all? So there are 1, 2, 3, 4, 5 members in group 3. Okay. So no one in group 3?
Hello,
Yes?
can you hear me?
Yeah. What's your name?
Lê Gia Minh.
Okay. All right. Lee Jiamin. Okay, go ahead.
Yeah. So the information of no muscle atrophy of weakness is to rule out the neuromuscular disease and the central nervous system disorder causing muscles weakness. The patient's muscle and their associated nerves function properly without condition like neuropathy, homeopathy, motor neuron disease. For example, like ALS.
All right. Very good. Very good. Thank you. Right. So muscle atrophy, again, ataxia, when you have problem with balance, right? When you want to walk normally, you need not only the nerve, right? You also need muscle as well. So if you have muscle atrophy, right, or the shrinkage or the death of some muscle cells, then it will cause weakness, right? So it will cause ataxia or weakness. So that might lead to loss of balance or loss of the strength. This is similar. You can test muscle strength and see if the patients have the strength. For the leg, you can ask them to stand on top of the toe to see if they have the strength, normal strength. Or for the hands, you can like pull hardly on the hand and they ask them to resist, right, your force, for example, right? So in order to test like your friend's answer, right, is there any other underlying problems that cause muscle weakness and then leading to these ataxia problems in the patients? Okay, so the answer for this check is no sign of muscle atrophy. That means the muscles are okay. The muscles are function normally and there's no weakness. So the signal through the nerve coming down to the muscles, everything is okay. Okay, there's no other problems because there can be another problems. And even, other toxins, right? There are different channels, different medicine, different toxins that can block several channels and then lead to muscle weakness, right? So those can also be cause of ataxia as well, okay? But in this case, no problem. So we're good, okay? Move on. Good job, right? So again, this is just a review. When if you still don't understand what's going on, go back and review these, lower motor neuron lesion, upper motor neuron lesions, what's going on in the reflex, right? So continue. Next questions. Information from H, I, and J. Okay, H, I, and J. Any group wants to volunteer? Okay, let's try. If no volunteer, I will call group 5. Group 5.
Hello.
Yes.
About a question, we answer the absence of international tremor suggests a vestibular disorder, not cerebellar dysfunction. And international tremor is linked to cerebellar condition worsening with voluntary movement. So the lack of tremor power to vestibular ataxia supporting BPPV which is triggered by head movement and not associated with international tremor. This
Okay, so intentional tremor, right? Intention. So like intention means, you know, you're paying, like you focus, you're doing like, okay, I'm gonna move now. So the starting or the stopping of the movement, right? The tremor that happen when you move, right? That's called intentional tremor, right? So in this case, no intention tremor, right? So, and your friend is correct. So this information from the edge, well, if the patients have the intention tremor, then it's the sign of cerebral problems. Okay, it's one of the key signs for cerebral problems. Okay, so in this case, no problem with cerebral, right? Because cerebral is also important to maintain balance as well. Remember, coordinations of the movement. Okay, so in normal situations, cerebral should, you know, give some feedback, helping to maintain normal balance. Okay, so in this case, cerebral is normal. What about eye? What about eye? We can do other group as well. Group 4, you want to talk about eye? Why do we have to test the eye? I and J. Let's answer I and J. Group 4.
Can you hear me?
Yes.
So the patient has normal vision, and when there is a double vision, that can occur when there's cranial nerve dysfunction that affect the eye movement control. So the normal vision, there's no problem there's no nerve dysfunction that affects this one. And for the normal hearing, so there's no disorder that affect both the auditory and the vestibular system in a patient. So since the patient dizziness is triggered by head movement, but there is no hearing loss, that suggests a peripheral vestibular disorder, which affect the inner ear or the nerve that carries balance signal to your brain.
Okay. Okay, good. Any other groups want to add anything here about H, I, and J? Right? So vision, like I said, vision is another input, right? That help with maintaining balance or make you, let's say if you walk, imagine if you walk, you know, and then you close your eyes and walk, of course, opening eyes, you will have better balance, right? That's why the eyes give you important input as well, okay? So that's why if you have problems with vision, you know, for example, double visions, right? So it can be several problems along the track, right, of the visual system, right? If any of that has having problem, you can have, sometimes you have the dizziness or vertigo as well if you have eye problems, right? You know, some of you that have like eyesight problems, when the glasses are not working very well, sometimes you feel dizzy as well, right? So that's possible cause, right? And so that's why we want to make sure that the vision is normal. Okay, so that's why we test the visions, right? Hearing, because we know that the inner ear is important, right, for balance as well, right? So testing hearing. So even though the apparatus, the auditory apparatus and vestibular apparatus are separated, right? Auditory and vestibular apparatus are separated. But sometimes if you have infection, if you have ear infections, you can disrupt both auditory apparatus and vestibular apparatus as well. Okay, so those are, you know, one of the examples. Or if you have, you know, specific problems in the auditory apparatus, then you have the problems with the hearings, right? Any hair cells, you know, inside the cochlea, any problem with that, then, or any problem with the nerve, then it can cause a problem with hearing, right? So in this case, you want to really make sure that, well, what happened to the inner ear, right? Especially this hearing part, right? So there's nothing wrong with the hearing part of the ear, okay? So that can, rule out infections or, some problems within the auditory part, okay? All right. So nystagmus. Okay, nystagmus. Anyone want to answer this question?
Teacher,
Yes.
I'm from group 2. I'm Ming. I heard you call me earlier, but my Wi-Fi back then they have some
Oh,
trouble. So yeah,
okay. You want to answer this question?
yeah.
Nystagmus. Okay, go ahead.
So nystagmus suggests like abnormal input from the vestibular system in peripheral or central. So here is the test about the vestibular function and ocular reflexes. The importance of this is if the nystagmus at rest without gaze fixation, it will highly suggest the peripheral vestibular dysfunction. And if unidirectional, horizontal, or subspressed with fixation, this will support the PV or vestibular neuritis, which the PPPV is might be the suggestion for this disease for the disease of this patient, and combined with the positional vertigo, it is strongly supported that this is the diagnosis of PPPV. Yeah.
Okay, very good, very good. I hope everyone can imagine nystagmus, right? I will expand that a little bit, but I have a question. So basically, nystagmus is the rapid movement of the eye, right? It's the movement of the eye when your head turns, right? And usually the normal nystagmus happen when you turn the head. But in this case, it's called spontaneous nystagmus. That means you did not turn your head and the nystagmus occur, right? So that is a result from something. Usually you have the 3 semicircular canal, right? This is just a review. Whenever you turn or you move your head in the angular motions, right? Turn up or down, turn sideways, or left or right. Then the semicircular canal will send the signal to the brain, right? So this is a zoom in right inside the semicircular canal. Remember, you have the hair cell that are covered with the cupula, right? So anytime you turn, depends on what direction you're turning, right? The endolymph or the liquid inside the semicircular canal will move and then bend this cupula and cause the hair cells to move, right? So to bend the cilia. And when you bend cilia, what happened? Anyone can answer me? What happened when the cilia is bent? What's going on?
It opens the channel for K plus to move in the cell and depolarize this started action potential and send signal to the olfactory parts.
Auditory, very good. Auditory, right? Olfactory is the smell, okay? But very good, correct. The potassium channel, right? K plus potassium channel. So there's a mechanical receptors, right? Or potassium channel to be specific on this cilia, right? Whenever it bends, it changes the conformation. So it's open. The channel is open, and then the potassium flow inside the hair cell, because in the endolymph you have high level of potassiums, right? So when the channel is open, it flow inside the hair cells and depolarize these hair cells. So then the hair cells can then activate the nerve, action potential travel through the auditory nerve, right? And arrive in the brain, okay? So that's, not auditory nerve in this case, vestibular nerve. Okay, so together with the auditory nerve, it's combined together and arrive in the brain. All right. So this is example. If the semicircular canal is activated, right, you can have like, you know, the side that is turned is increasing firing, right? In the same time, there is a reflex. So if you remember last time we talked about the track, right? When the vestibular nerve arrive in brainstem, one of the track is down to the spinal cord, right? Another track is, it also sends a signal to ocular muscle. What is ocular? Where do you find the ocular muscle?
The eye, the retinal.
Yeah, the eyes, right? So when you move your eyeballs, right, left or right or up or down, right? When you move your eyeball, so this reflex will cause your eyeball to move, right? Vestibulo-ocular reflex, right? We can do some kind of experiments together. So in normal situations, you can have nystagmus, but those nystagmus is called physiological nystagmus. Okay, that means when you turn, let's say you turn right, the semicircular canal is stimulated, right? And then you have this physiological nystagmus, which is the signal that will make your eyes move to the right. Okay, so usually if you do the experiments, like I'm gonna turn on my video a little bit so you can see my demonstrations. And you can do it like with yourself also. Imagine when you walk around, right? And let's see. When you walk around and then you know, you never walk like a robot, right? Your head is actually moving all the times, right? So your eyes are actually moving also. And it moves based on where your head, you know, move. So if you can do experiments like here. So put your finger like on the right. Put your fingers like on the right and then look in front and then turn to your right and look at your finger. Okay, turn and then look at your finger. So you will notice the head move first, right? The head move first. And then the eye is actually a twist and then move following your head. All right. So that's, and imagine if you turn your right and then your eyes are not moving, following your head, then you have problems, right? So usually when your head move, your eye move, follow that, right? How does your eye know that it has to move to the right? Because of these vestibulo-ocular reflex, right? That's a simple explanation, okay, of one of the reflex. So the head turning not only tell your body, not only tell your spinal cord to maintain, you know, to adjust muscle contractions on your leg, but it also tell your eyes as well. Okay, so the eye movement. So everything is connected. Okay, and that is called physiological nystagmus, right? However, in this case, when the nystagmus occur without head turning, right? That is called spontaneous nystagmus, okay? Or sometimes, especially in these patients, the nystagmus occurs strongly, right? So when they turn their head, they have like very strong nystagmus, okay? That means the signal is somehow stronger than normal, okay? It should not be that strong. The signal is super strong, okay? Stronger than normal, all right? So what can be the problems? How come? So after we rule out different things, right? We rule out the several input that control balance, right? The eyes is normal, vision is normal, the upper motor neuron is normal, cerebella is normal, lower motor neuron is normal, muscles are normal. You know, there's no blood pressure problems. So what's the problem the patient has? Any group want to answer this question?
Yes.
Okay. What group?
We are group 1.
Okay.
Yes. Based on the symptoms and along with the spontaneous nystagmus and no signs of central nervous system involved, the most likely is BPPVs or benign paroxysmal positional vertigos. It is caused by the movement of calcium carbonate crystals in the semicircular canal of the inner ears, causing the balance disturbance and leading to the service dizziness when the changing head position.
Okay, very good. Any other groups? Are there any groups that get the different answer from these BPPV? Okay. Yes, go ahead.
Our group have BPPV, but we also suggest another possible diagnosis is the vestibular ataxia. Yes, because they have similar symptoms.
Okay.
Yeah.
All right. Any other group? Any other possibility? They're very good.
I also have one possible option. That during find out that we have two cases about like the first one like the other one just said that we have the vestibular ataxia and also the BPPV. But during finding the information about these two, I also find out that there are some symptoms also related to the vestibular neuritis, also one of the cause that I think also possible for the disease that the patient may have been through, I guess.
Okay, very good. Any other? And what groups were you from? Those two?
We're from group 8.
Okay. Any other possible answer? I like to hear. That's very good. That means you're looking for possibilities. Okay, so yes and no. Okay, so that's a possibility from the symptoms, right? From the symptoms from the physical examination, it seems like something definitely happened with vestibular system, right? So everyone agree with that. Seems like vestibular system is having problems, but now we will zoom in, right? So what type? There can be several problems with vestibular system, right? Now, how can we differentiate? How can we differentiate that? Oh, it's just BPPV, or it's something, with vestibular ataxia, or some, damage in the vestibular system. Anyone can think of, anything that we can rule out. Like we can come up with final decisions. Like, oh, I think this is the best answer. Okay. Yeah, go ahead.
I haven't dived into detail yet, but I think each disease would have a biomarker, and those biomarker could come from imaging tests or genetic tests or blood tests. So maybe further testing could help us narrow down the exact disease.
Okay, so the answer, not much of the blood test, but yes, further tests, right? For example, if you look at brain scans, you can probably have some problems with the brain or any tracks, right? But one of the simple information that you can pay attention or notice is the symptoms of the patients. Remember the first questions that I asked you to look at the symptom of the patients. The symptoms are transient, right? So that is one important thing that can differentiate between BPPV and other vestibular problems, right? Because if you have problems with the nerve tract, tracts, right? With the vestibular tracts or any, part of the brains, usually the symptoms tend to last longer, right? Or permanent or last longer. But when symptoms appear transiently, that means there only some trigger, like once in a while, the trigger, and then it's, quiet. And then the trigger comes again and it's quiet. Okay, so that is one thing that really, from at least before going deep into like further investigation or, brain imaging, you can get this information and then come up with, decisions. Okay, so let's look in detail a little bit, right? So before we talk about BPPV, everyone has to understand this slide, right? So that's why I like this case, because it's a good review, right? So everyone has otolith organ. This otolith organ usually located in the otolith organs, right? Otolith membrane here, located inside the saccule or utricle, right? Together, this is called otolith organs, right? They're not in semicircular canal, right? They're usually attached, these calcium carbonate crystal are attached to the membrane of otolith organ, okay? So when you're young, if there's no trigger, anything, it will remain intact and attached to the membrane of the otolith organ. So this is like a gel-like membrane, okay? And it would just move when you have the gravity, right? When you move, when you have the linear motions, right? Bending, or bending your body, for example, or accelerating, decelerating, okay? Or, forward, backward motions, right? So those are the only time that it will bend, right? And then when it bends, then you detect that movement, linear movement, okay? But what happened in this case is that these otolith or the stones or the calcium carbonate crystal fall off the membrane of otolith organ. And then instead of located inside the otolith organ, it fall into semicircular canal, okay? Because there's some connections, right? And so when it fall into the semicircular canal, you can imagine this is the semicircular canal is filled with fluid, right? So whenever you have this heavy weight of the crystal moving around, then it's going to precipitate the movement of that fluid, okay? It's going to make a movement of this fluid stronger than what it should be. And it's going to cause the movement of these, cupula and bend the hair cell, right? And cause the confusions of the brains, right? Sending a very strong signal to to the brains, and then that can cause a bunch of loss of control of movements, confusions of the signal for the balance, for the movement, right? And dizziness as well whenever you have conflict informations or strong activations coming from the vestibular system. It can cause the dizziness feeling or nausea, all right? So it can be floating inside the semicircular canal, or worst case, it can even attach to the cupula in the semicircular canal as well on these ampulla, okay? So, and these problems, it's called BPPV, and this word comes from benign paroxysmal positional vertigo, okay? So it's the vertigo that is caused when you change position, right? And it's sudden attack. Paroxysmal mean like immediate, like sudden attack. And benign is, it's not harmful. It's not like life-threatening or anything, okay? That's why we call it BPPV, okay? And this is very common, okay? My mom has it, and just last year I had this too. So I'm very, I have a direct experience for this BPPV, okay? And the symptoms with this is, again, exactly like these patients, right? Dizziness, vertigo, especially when, you move. When I get up from the bed, boom, it's like, boo, it's sometimes you would feel like the whole house is like rotating, okay? Or sometimes the patients can feel that themselves are rotating as well, okay? And so this the problems cause symptoms because we know, right? We explain everything's here. So hopefully you know the otolith again, and then now it's not in the right place, right? It's falling into the semicircular canal. Okay, so what caused these problems? How come? Any group want to answer? Any group haven't answered yet. We have 7, 9, and 11. Group 7. What are the possible cause of the problem? What caused BPPV? Group 7. Anyone?
Can I answer? But
Yeah.
I'm not in group 7.
Oh,
Okay.
okay. Are you in group 9 or 11?
11.
11, right? Okay, go ahead.
Yeah. So so as you have explained before, so we guess that maybe under itching or head trauma or inner ear infections can cause this crystal to dislodge and migrate into the semicircular canal. So that is and then it can be because it's the lowest position when in laying down. So when your head moves, it can be displaced it autolytic crystal stay into the endorphin and continue moving even your head stops and make that symptom.
Okay. Can you repeat again what can be the cause, the possible causes?
Aging, head trauma, or inner ear infections.
Okay. All right. Anything else? Any other group? Group 9 and group 7? Any additional answer?
I have additional answers.
Yeah, what group are you from?
Group 7.
Okay.
I think it's maybe also due to the prolonged immobilities, like after surgeries or illness, and it can cause the crystal sift into the semicircular canals and can cause the PBBV.
Can you repeat the first part again? Sorry.
It can due to the prolonged immobilities, like
Oh, I
after
see.
the surgeries or the illness, can
Okay.
cause the crystal sift into the semicircular canal.
Okay. All right. Okay. Anyone else can come up with the cause? All right. Okay. So, cause of BPPV, most of the cases are unknown. It's really, no underlying cause at all. It just happened. Okay. And I'll come back to this later. But so the majority of the patients with head trauma, right? When they get older, or if the head trauma occur with aging when they are old, then they have a high chance of developing these BPPV. Okay, because like the group 11 answer, so most common cause is aging. Okay, you can have when you're aging, everything is degenerate, right? So those gel can also be it's not really degenerate, but it's not as as complete or effective as when you're younger. Okay, so you can imagine everything is loose, right? Everything is loosened, so those otolith has higher chance to fall off, right? However, if the older elderly have head trauma or accidents, then the chance would even be higher. Okay, and even the younger populations, if they have like strong head trauma, that impact can knock off those crystal somehow, right? So that can also happen. Okay, infections as well. Infections of the inner ear or vestibular nerve can also cause these BPPV as well. And vestibular nerve degeneration itself can also be a part, right? Now, the unknown part, and there are actually recent research showing that genetic is playing a role. So if you have some in a family that have BPPV, you might have a chance to develop that BPPV as well, okay? And I think that's what happened to me, right? So I never had any accident, head trauma, any infection or anything, but the symptoms just like develop like out of nowhere, okay? And my mom has that, right? But my mom also has the trigger with like head trauma. So, and there's a study with the twin. So, you know, two persons, right? They're twins and they're like 35 years old and they live in, you know, two states in the US, like very far from each other. But they developed BPPV at the same times. Okay, so that's one of the proof that genetics somehow playing a role. But we don't know yet like what the genetic influence, right? It can be something related to the proteins that make the membranes, the otolith membrane, or some other things that we don't know yet. Okay, so but mostly really unknown. Now, when this happened to the patient, and it's very common also, especially with the older people, how do you treat the patients? Okay, group 9, you have to answer these questions now. Group 9. Anyone from group 9?
I'm the 9 from group 9 and I will answer this question.
Okay.
So firstly, when you have this order, you normally will following with medications for nausea, medication for severe vertigo, following with the observations. Normally I research they recommend the Hopley maneuver, like you reposition your ear in a way that it makes less crystal, so the symptom will not like worsen.
Okay, very good.
And if
okay, go ahead.
And if the disease go worsen, you must go through surgery.
Okay. All right, very good. All right, good job, everyone. So let's see, how do we treat this patient? Unfortunately, there's no specific medicine, okay, to solve the cause of the problems, all right? Usually those otolith or the calcium carbonate crystal will dissolve by itself by time, okay? But it can take a while depending on how big, how much of the stones or the crystal that are, you know, falling out or and stuck inside your semicircular canal. Also depending on if it's just freely floating or if it's attached to the cupula, right? So the symptom might be, the severity of the symptoms might be different, okay? If you have like a big piece of, you know, the stone, then the symptom might be quite severe and it takes very long time for it to dissolve, okay? Sometimes can be weeks, sometimes, you know, if it's, especially if the problems happen like with the degeneration, you know, those can happen, you know, for a long time, on and off, right? Every time you move, you make a movement and everything. So there's no specific medication for that, but you can help relieve the symptoms by, yes, like your friend said, by, you know, prescribing some medicine for vertigo, right? And usually those are histamine blocker, right? So basically blocking the signals to, you know, that make you feel dizzy, make you feel nausea, vertigo, those feeling, right? But it doesn't have anything to do with the stone itself. Okay, you just have to wait until those stones, you know, is resolved by itself and then the symptoms disappear. Okay, but most importantly, the advice that you give the patients are the most, important piece of, information, because they will have to aware, they have to adjust their behavior, right? Because if they notice that, okay, there's these problems happen, there's stone inside the semicircular canal, they have to move the head slowly, right? Because if they move the head fast, you can imagine the fluid will move fast, right? And it will precipitate, it will make those crystals move faster, and it will even trigger the symptoms, right? So the nerve will fire, will be stimulated like super strong, so that you will feel, even worse. You feel like, very strong vertigo, strong dizziness, and sometimes you can even fall, right? Ataxia, because you can't maintain your balance. So a lot of patients can fall, right? So the next advice, you will have to tell them that be careful with the result, right? So the problem itself, it's not harmful. The stone doesn't cause any, harmful effect or anything, but the result, the symptoms, the loss of balance can cause the fall, right? The dizziness and, loss of balance, then the patients can fall immediately. And if it happened to, older people, then they can break some bones, right, in their bodies. Or if you're driving or riding motorcycles, right, especially in Vietnam, you have a lot of people ride motorcycles, including my mom. So when that happened to her, I have to tell her, like, stop riding motorcycle, like, she can, I bought her like a 3-wheel motorcycle, at least, because she doesn't have to like maintain the balance too much, right? Because you never know when it's going to attack again, right? And I want to emphasize this because it happened a lot with the elderly. So if you know your mom, your grandfather, grandmother that have similar symptoms for this, now you have some knowledge to tell them, right? Move your head slowly, move your body slowly, and be careful. Do not operate machine, and try to avoid, driving cars or motorcycle if the symptoms, developed, right? And sometimes you might have to wait, until like weeks to make sure that the symptom doesn't come back again, right? Because it can attack suddenly anytime, right? And so those are important advice you give to the patient, right? Physical therapy is the most effective way, okay? And I actually treat myself, not myself, but here we have the, physical therapists that everyone have to learn how to deal with it, BPPV, okay? They're gonna move your head around based on the locations of the stones in your ear, right? In order to trigger, make the stones coming out of that semicircular canal. I have the video for you in a second. But if the problems persist, okay, and if any of these doesn't help, if it's like disturb your life, the patients like vomit all the time, they cannot walk, they cannot move at all, even though you treat with any medicine, the vertigo, the dizziness doesn't go away, they throw up, the whole time. So that is considered like severe, right? So in that case, you might have to consider blocking the canal or do the nerve surgery, vestibular nerve surgery, right, to prevent more severe effect, right, in a severe case, okay? But that's happened rarely, right? Okay, so this is example. Now you can search in YouTube actually, manure for BPPV. There are different types of manure, okay, based on we have 3 semicircular canals, right? So there's different types of manure depending on which semicircular canal that you have the stones, okay? In this case, in this specific video, it's the stone that located inside a horizontal semicircular canal, which is the one that you use to turn left or right, okay? And this is how you do. Oops, sorry. And it's called barbecue manure, and you will see why it's called barbecue. Can you hear the sound? Can you hear the sound?
Yes, we can hear the sound.
Okay, I just want to make sure. All right, let's try again.
Normally, only with head movement does fluid within the inner ear also move, informing the brain that a head turn occurred. However, should a crystal called an otolith gets displaced into the lateral or horizontal canal of the inner ear, BPPV dizziness occurs. Fluid movement occurs due to the crystal rather than head turns, causing the brain to think movement has occurred even though none has happened. The Lempert or barbecue maneuver is performed to treat this lateral canal BPPV by trying to get the loose crystal out of the canal. This maneuver is started by turning the head 90 degrees while the body is laid back. If BPP is present, side-to-side eye twitching called nystagmus will occur. After 30 to 60 seconds, the head is then turned such that one is facing down, and this position is again held for 30 to 60 seconds. The head is then further rotated another 90 degrees. When performing this maneuver, another individual can help with these position changes. Finally, the Lempert maneuver is completed by rolling the head and body back to the original starting position before sitting back up. At this point, the loose crystal should have come out of the canal, causing no further problems. So what's going on with these position changes? Essentially, the head is moved in such a way to manipulate the crystal to fall towards the canal opening. With each position changes, it takes about 30 to 60 seconds for the crystal to settle into the most dependent position in the canal. If turns are made before the crystal has a chance to settle, the crystal may fall back the wrong way and the maneuver will fail to work. It is also important that each of the head positions are fully turned, or else the crystal will not settle to the correct position in the canal and the maneuver will fail. Also, if the position changes are done too slowly, the crystal may not settle quickly enough from lack of momentum and the maneuver will fail. Once the crystal falls out of the canal, the dizziness should resolve if due to lateral canal BPPV.
All right. So hopefully you can see, they turn around, right? It's like barbecue. And so the purpose again is to make those crystals come out from the semicircular canal, right? So the time, the speed for each turn is important, right? Because if you have to make sure that you wait long enough for the crystal to turn, and then you move, you continue to move, and then you get up, right? So make the crystal fall back out from the semicircular canal. And you can see nystagmus also, right? Every time you turn, because every movement that the crystal moves, it will create signal inside the vestibular system, right? And then it will also send it to ocular muscle, remember? So vestibulo-ocular, right? And so that can trigger the nystagmus, right? So because it's a strong signal, so that eye can move like quickly, significantly, all right? Okay, so this is a summary from, what we discussed. And this case can also emphasize how all of these, systems are important to maintain your balance, right? To maintain the posture, to maintain balance, right? Cerebellum maintain coordinations of the movement. Motor system, of course, it control muscle contractions, right? So, and you have both upper neurons, lower neurons, lower motor neurons, and then the muscle itself, right? In the motor system. You have visual system also, vestibular system, vestibular system, and somatosensory system serve as input, right? Sensory input to your brain, and make sure that, information that the motor system sent down to the muscle are okay. So this is like an important feedback system, right? So same information here, right? So you have the two side, you have the you have the input, right? You have the input here, visual, somatosensory, vestibular systems, right? And so you have the input from the cortex down also. So this will control the movement, right? To the posture, to maintain the posture or any movement, right? Remember the signal can also, especially the signal from the vestibular system can also regulate the eye movement as well, right? And in the same time, your brain also aware of any movement that occur as well, okay? So several systems are involved. Anything that can also cause similar problems than to the BPPV that cause, you know, dizziness, vertigo. So one keyword, one other things that you can notice here is that if the visual information, somatosensory informations, and vestibular system are going in the same direction, giving same information to the brain, then you have, you know, normal movement and you don't have any problems with dizziness, with vertigo, okay? But in this case, the vestibular system is having problems. So it's like firing very strong signal, right? Telling your brain like, you know, very strong movement. In reality, you did not really make that big of a movement, right? But it's this abnormal signal, right? In that case, the confusions from these, you know, input come to your brains, and that can cause, you know, confusions of the brains, and it can cause, you know, a lot of consequence, vertigo, dizziness, right? Any other examples that mimic that kind of like similar to this, but it's not BPPV? Like it's some kind of information or situation that give the conflict between the visual, the somatosensory sensation, and vestibular, and can also cause dizziness or vertigo. Anyone think of any situation? Any sickness?
Car sickness, motion sickness.
Exactly. So the motion sickness, right, can also cause this, you know, dizziness or vertigo sometimes, right? Even sometimes can cause ataxia, you know, sometimes you kind of like loss of balance, right? And the reason for that is, especially the motion sickness, right, is that you imagine if you sit in the car in a taxi, right? In Thailand, especially the taxi are terrible. They drive like crazy. So sometimes they accelerate, like going very fast, and then they stop, they go again, and they stop all the time with those traffic, right? So your somato sensations, sensing you sit down, right? Sitting like quietly, it doesn't have any signal to your brain, right? Your vision also, most of the time, what do you do when you sit in a taxi? Look at your phone, right? If you look at your phone, again, your eyes are not sensing, you know, any movement, right? It's just looking at your phone. But then your vestibular system is working so hard, right? Because of that linear motions, right? Acceleration, decelerations. And that is similar to the signal, right? That you have from BPPV, right? But that in that case, linear motion is ortholith, right? But again, strong signal from just the vestibular system can confuse your brain, and then can cause those kind of, you know, motion sickness symptoms. Similar thing, similar idea when you go on the boat, for example. Everything is, you sense everything is normal, no movement, but vestibular system is working so hard, right? And you sense that motion sickness. So that's why they say sometimes it's helpful if you sit in a car, and if you are sensitive, right, to these kind of motions, then it's better that you look in the front, right? That can help to coordinate, make the, you know, signal from the vestibular system going in the same direction as the visual system. So your vestibular system sensing the movement, your eye can also see that you are moving, right? So that can somehow help with the motion sickness, okay? But the sensitivity of each individual in the vestibular system is different. Some people don't have any problem at all, right, with motion sickness. Some are having like very sensitive, right, vestibular system. So they can't even, you know, like me, for example, I'm very sensitive. I get car sick all the time, right? Anyway, so this is just, you know, together it's kind of like emphasize what we have learned about motor system, sensory system, and put together in, the function as the balance or posture control. All right. Any questions related to this case study? Any questions at all? No question? Okay, no questions. Then let's do quiz of the day. Let's do quiz. Okay. Oh, hold on. Are you seeing the slides right now? I'm gonna copy this and then paste in the chat box. Okay, so everyone should be able to go in the quiz, right? And if you finish, so now let's say about 8:50, let's take 15-minute break. So 8:05, we can come back, okay? So if you submit the quiz, you can take a break and then come back at 8:05. I mean, 9:05, sorry, 9:05. And at 9:05, I'm going to close the quiz, okay? So I'm gonna accept the quiz until 9:05, all right? Anyone is having problems with accessing the quiz? All right, okay. We're gonna have another quiz again at the end of today's lecture, okay? So there will be 2 quizzes today. When we come back, we will continue with another lecture that I already sent you the handout in the email, okay? We'll talk about higher brain functions, all right? I'll see you in 15 minutes.